Doug? Well, good evening, everyone. For those of you that don't know me, my name's June Rogers. I've been working with children with bladder and bowel problems for, 35, 40 years. So a long, long time with a special interest in children with Down syndrome. So tonight we're going to do a quick overview of bedwetting, what the possible causes are and the treatment options available. So what is bedwetting? Well, bedwetting is defined as an involuntary wetting during sleep at least twice a week in children older than 5 years. And children need to have been dry in the day for at least 3 months before we consider bedwetting is actually a problem. And it's over the age of 5, it's considered a medical problem in children with no underlying linked medical problems such as diabetes insipidus or on overnight pump feeds, when obviously they're getting a lot of fluid and we don't expect the children to be dry then. And it's actually considered to be normal part of the child's development in children younger than 5 years of age, because it can take up to the age of 5 for children's bladders to fully mature. So bedwetting is very common, and I just want to say here that bedwetting in children with Down syndrome who are toilet trained in the day, the bedwetting is nothing to do with having Down syndrome. Bedwetting is just very, very common, and we know in young children it happens in about 50% of children, and children at 5 about 20%, and as children grow, obviously the incidence of bedwetting decreases, but we know in adults that actually 1 to 2% of adults will still wet the bed. So what causes bedwetting? Well, bedwetting, unlike daytime wetting and toilet training, bedwetting cannot be taught because it's a physiological maturation of the bladder, the kidneys, and the production of a special chemical messenger called vasopressin, which tells the kidneys to concentrate the urine during sleep. So a problem in any of those areas can actually result in bedwetting. So it may be that one of the contributory factors to the bedwetting is making too much wee at night. Normally when we go to sleep, there's a special chemical messenger from our brain which goes to the kidneys and say, right, sleep time, only produce 1 bladder full of wee. When we go to sleep, everything slows down. Our heart rate slows down, our breathing slows down, and our kidneys should slow down and reduce the amount of wee. If you think about it, if that didn't happen, we'd all be up in the night going once or twice to the toilet. So making too much wee at night is one cause. And even if your kidneys make the usual amount of nighttime wee, if you haven't got a bladder that's big enough or a decent capacity, then even the usual amount of nighttime wee it cannot hold. And it may be because the bladder is small, or it may be that it's a bit twitchy and irritable, and it's not able to relax fully to hold a full bladder of wee. And the other issue is that even when the child is asleep, normally when we're asleep and our bladders are full, our bladder will send strong enough signals to our brain to say, wake up, you need a wee, you need to get out of bed and go to the toilet. For children with bedwetting, they have what is called lack of arousability. For some reason, the part of their brain that should respond to bladder signals, it doesn't. And so even though the bladder is full and sending signals to say, wake up, you need to get out of bed and go to the toilet, the child doesn't wake. And parents will often say, oh, a bomb could go off and the child would sleep, though, really deep sleep. And it's not that they're deep sleeping, because we know that bedwetting can happen. We have waves of sleep. We have light sleep and deep sleep. And bedwetting can even happen during the wave of light sleep. It's this particular lack of arousability. And all children who wet the bed have a problem with arousability to a lesser or greater degree. So this sort of explains it in a way. So one contributing factor is what's called nocturnal polyuria. That's the medical term. And it's because there isn't enough of the chemical messenger vasopressin, which tells the kidneys to reduce how much wee is made during sleep. The other issue is a small bladder and this lack of arousability. And as you can see, all children have a problem with lack of arousability to a greater or lesser degree. If they didn't have that, they would actually wake up and go to the toilet. Some children have a problem with lack of vasopressin. Some children have a problem with their bladder, and some children have a problem with everything. And this is called, over the age of 5, this is called enuresis. And we know there's a strong genetic influence, and it may be that parents, grandparents, uncles, siblings also had a problem with bedwetting, because we know that, as I say, there is a family link to having a problem with bedwetting. So what we need to do is find out why the child is wetting the bed, because if we know the contributory causes, then that helps us target the treatment. So we ask about how much the child is drinking and when they're drinking. Obviously, what usually happens is they don't drink very much during the school day. They come home from school, they're really thirsty. So all their fluid intake is during the evening. And obviously, they then go to bed and they haven't got time to weigh out all that, what they've had to drink. So knowing when, how much, and the type of drink as well, because studies have shown things like blackcurrant juice, things with lots of colours in, can actually irritate the bladder, and that can contribute towards the bedwetting as well. So how often are they doing a wee during the day? That will give an indication of their bladder capacity. If they're doing lots and lots of little wees, that suggests they haven't got a decent enough bladder capacity. And we can actually measure how much a bladder can hold, and we can work out the bladder capacity for the child's age, which we're going to do in the next few slides. And what time of night does the child wet the bed? Because that'll give a clue whether they're wetting the bed because of the problem with their bladder, or they're wetting the bed because of the problem with lack of vasopressin. And is there a problem with underlying constipation? Because if the child is constipated and they've got a loaded rectum, which is full of poo, that's going to squish against the bladder and prevent it expanding and holding a lot of weight. So once children are toilet trained, we'd expect most children to wee between 4 to 7 times a day. So if you've got a child that's weeing 10 times a day and they're having not an excessive amount to drink, that suspects that may be an issue with their bladder. And so to work out the size of the child's bladder, we've got this simple equation, which is the age times 30 plus 30. When babies are born, their bladders hold about 30 mils of urine. And as children grow, quite conveniently, their bladder size increases by about 30 mils a year. So, for example, an average 5-year-old is 5 times 30 is 150, plus the 30 they were born with, 180. So an average 5-year-old's bladder capacity is about 180 mils. And that equation works up to about the age of 11 or 12, when most children's bladders reach adult size. And wetting the bed before midnight, within a few hours of going to sleep, could suggest lack of vasopressin. So it's really important that children have a sort of very basic assessment to try and suss out exactly what the contributory factors to the bedwetting is. And there are some national guidance around bedwetting, and this is the quality standard, which was, it was written over 10 years ago, but it's still true today. And they've actually identified that even children with physical and learning difficulties that bedwetting can be treated. So please don't be fobbed off. Oh, it's because your child's got Down syndrome. Oh, it's because your child was late getting toilet trained. Bedwetting, as I say, over the age of 5, if the child has been dry in the day for at least 3 months, then, it is a problem that can and should be treated. So there are simple things that you can do to help try and improve, if not resolve, the bedwetting. So obviously, constipation is a big thing that a lot of children with Down syndrome have a problem with. So it's important to try and resolve that. The usual things that we suggest, lots of fruit and veg, and laxative treatment if the constipation is already in place. And getting into a good routine of regular drinks, regularly throughout the day, at least 3 drinks in school, and the last drink an hour before bed if possible. And we've talked about trying to avoid caffeine, which is in hot chocolate, and also coloured or fizzy drinks. Obviously ensure a wee last thing before bed. And if you've got a child who's in nighttime nappy or nighttime pajama pants, pull-ups or whatever, and you've noticed that sometimes the nappy or pull-up may be a bit dry or damp, or it's not as wet, you could have a go at taking the nappy off. Obviously make sure the mattress is well protected, because we know for some children they don't actually wet the bed during the night. It's when they first wake up and they're all nice and cozy in bed, and particularly if it's it's in the winter and it's dark, and they've got their nappy on for the very reason of doing a wee. Why should they get out of bed and trip to the toilet if they've got a nappy on and they can do a wee where they are? Thank you very much. So it may be worth having a few days without the nappy on, and obviously reinforcing to the child that if you need a wee, you need to get up and go to the toilet. And some parents will leave a little treat in the bathroom to encourage the child to get out of bed and go for a wee. A lot of parents ask about lifting. You can do it on an ad hoc basis, but it's not considered a treatment, and it's not something that we generally recommend. Most times the child is half asleep, they have no recollection of getting up in the night and going to the toilet, and what it actually does encourages child to wee when they're not fully awake, but also it's artificially emptying the bladder during the night, and it's not going to help the bladder develop a reasonable, good enough capacity to hold on to a nighttime wee. So it's something to do occasionally if you're staying away or whatever, but it's not something that we would recommend. So let's have a look. We've talked about the possible contributing factors to the bedwetting. So now let's have a look at it in more detail. So nocturnal polyuria is when the amount of wee produced during night is greater than the ability of the bladder to hold on to. Normally, when during the day, our kidneys produce around 60 mils of urine an hour. Obviously, it varies, time of day, how much you've had to drink, etc., etc. But on average, it's about 1 mil a minute. When we go to sleep, our kidneys, as I've mentioned, slow down the production of wee, concentrates the urine down to about 20 mils an hour. And that should happen. And obviously for children who wet the bed, that doesn't happen. And this is a little schematic graph to show you. So we've got on the yellow side the vasopressin levels, and on the sort of grey side is how much wee is produced. So here we have the level of vasopressin on a child who doesn't wet the bed. So during the day, it's a steady level. And when the child goes to sleep, the level of vasopressin rises. And as a result, the volume of wee is reduced from about 60 mils an hour to around about 20 mils an hour. And that should happen for all children. Now, for children who wet the bed, when they go to sleep, as you can see, the level of vasopressin doesn't rise very much at all. And as a result, the volume of wee produced doesn't reduce very much at all. And you can see how that works and why that can actually contribute towards the bedwetting. So the treatment for lack of vasopressin is just to top up the naturally occurring vasopressin, and desmopressin replicates the vasopressin. It replicates the bit that concentrates the wee, and it only acts on the kidneys, nowhere else. It tops up the naturally occurring vasopressin. It's taken an hour before going to bed, and the last drink is an hour before. So the child goes to bed at 8 o'clock. So you take the vasopressin around 7 o'clock. That's so it's really worked in the system as the child goes to sleep. So the last drink should be an hour before that, which is 6 o'clock. If you have a child who wakes up in the night and wants a drink, or goes and gets to the bathroom, gets the drink themselves, then vasopressin, top up desmopressin is not something that we would suggest, because it is important that children don't drink after they've taken the medication. And the treatment is usually anything from 3 to 12 months. It just depends on the child. Some children get dry spontaneously after taking it for only a month. Some children take a bit longer. So it comes in tablet melt or liquid form. The melt, it's like a little form of a rice paper, and it's good for children who can't swallow tablets, because you just pop it in their mouth and it instantly dissolves. And we start on a low dose, and the child is reviewed after the first week. It should work straight away. So, and if the child is dry, or there's really significant reduction in the amount of wee or the volume of wetting, then they can continue on that low dose. If no improvement, then the dose is increased to 2 tablets, 2 melts, or a ml of the liquid desmopressin. And what the normal treatment is to try it for 3 months and then stop to see what happens. Has the child become dry spontaneously during the treatment phase, or are they only dry because they're taking the medication? So we stop for a few days and see what happens. If the child is dry, fab, then we don't restart the treatment. If the child starts to wet, then when the treatment is reintroduced. And they can have as many 3-monthly cycles as it takes for the child to become dry. So what does NICE say about the desmopressin treatment? It can be used for children over the age of 5. If the child needs to get dry quite quickly, if you're going on holiday, or there's a specific reason why it's important for the child to, get dry overnight, or if the other treatment, which is the alarm, is just totally not suitable. So we know, as I say, that sleep arousal underlies all bedwetting, and to a greater or lesser degree. So the 2 main treatments are looking at the lack of vasopressin and trying to enable the child to become dry using an alarm treatment. And the 2 types of alarms, and you may well be aware of the wetting alarms. The body-worn wetting alarm we actually use a lot for toilet training in the day, or for children who've got a problem with what's called an overactive bladder, or have got a problem with daytime wetting. And the other is the bed alarm, which goes on the child's bed. And it depends what's available in your area. Most areas will have a bedwetting clinic, and you can access the clinic by a referral from your GP, or sometimes the school nurse can refer the child. And it may be, you may be given a choice, or it may be, sorry, we've only got this type of alarm. We are aware that in some areas alarms are not provided, that you may have to buy one. It just depends, unfortunately, where you live. So what does NICE say about using the alarm? it's to consider alarm if the child is considered mature and motivated enough to cope with the alarm. Thing about the alarm is the child has to take some responsibility. They need to wet the bed at least 3 times a week, because the more often the alarm goes off, the more the better the treatment works. And has lots of family support and good sleeping arrangements. So obviously alarm may not be the best option if the child is sharing a bedroom, or that you've got a new baby, or there's lots of other issues going on. They need to have some arousability, so that there are some signs that the child can be woken up during sleep, and particularly if they're not able to take the desmopressin. So the alarm clock is considered, and this is what we used to use before using an enuresis alarm, because to be honest, an enuresis alarm can be very disruptive, because not only will it wake the child, it can wake the rest of the family and including the neighbours. We had a family who said, the next door neighbour knocked and said, just to let you know, I think your burglar alarm keeps going off in the night, because we can hear it, because the child was sleeping in an adjoining bedroom to the neighbours next door, and the mum realised it was the child's enuresis alarm. And it has to be allowed, obviously, to wake the child up. So rather than go either to, and particularly if your child is on a waiting list with the enuresis clinic to get the alarm, or they say, sorry, you're going to have to buy alarm, before you buy alarm, it may be worth trialing, seeing how you and the child copes with waking up in the night. So you get an alarm clock and set it at roughly the time you think the child wets the bed. So even if you're not sure, then say 2 o'clock in the morning. And so you set the alarm for 2 a.m. and you show the child, this is a special alarm, this is going to wake you up to tell you to go to the toilet, and this is how you turn the alarm off, you press that button, whatever. And then so 2 o'clock the alarm goes off, and invariably the child is sleeping through it, so you have to get out of bed, and it's important you wake the child up. They need to wake up to hear that alarm, so you don't turn the alarm off. Come on, wake up, your alarm's going off, you need to wake up and go to the toilet. The child turns the alarm off, gets out of bed and goes to the toilet. If the bed is wet already, then, because when you use an alarm, the child doesn't wear a nappy, so you have to make sure the bed is well protected, and you can get special mats that the child can sleep on, so it saves the bottom sheet and the mattress. And so if the bed is already wet, then the next night you'd set it for 1:30. If the bed is dry, then the next night you'd set it to 2:30, because what you're trying to do is set the alarm clock for when a wee is almost due. And so the time is adjusted. And if everybody copes with that, then great. Yes, you can go about using the alarm. Some parents actually just continue using the alarm clock and gradually adjust the time, because what we find is, and there's been lots and lots of studies about using alarms, and no one is really sure how it works. A lot of people think, oh, it teaches the child to wake up in the night and go to the toilet. What actually happens, that children who become dry using alarm actually sleep through the night, and they think it's something to do with the pelvic floor and increasing the child's bladder capacity. Not really sure, but we know that using alarm does work, although it can be, as I say, quite disruptive. And even with the best will in the world, and I've had children with Down syndrome, really enthusiastic. We've had lots of practice in the day, they pretended to go asleep, we've set the alarm, they've woken up, turned it off, gone, and yet in the night, half asleep, everything goes out the window and they forget exactly what they need to do. And it can be quite distressing for the child when they've forgotten how to turn the alarm off. So what we suggest, that do have a go at using the alarm clock first, unless you're quite confident your child will cope very well with the enuresis alarm. So at the beginning, parents need to supervise, obviously, the child waking up and going to the toilet. And the first sign of progress is the child being able to wake by themselves without the parent having to rush out of bed. And hopefully as well, you'll find that what happens when normally when the alarm goes off, by the time the child's turned the alarm off, they've flooded the bed, they've done the big wee and emptied their bladder. But as time goes on, they're able to wake up quicker, stop themselves weeing, so the size of the wet patch in the bed gets smaller and they're able to do more wee in the toilet. And as I say, ultimately, the child is either able to wake up spontaneously and go to the toilet, or more commonly sleep right through and wake up dry. So, as just to conclude, becoming dry at night is a physiological process, and any delay in becoming dry is not related to having Down syndrome. Dryness cannot be taught, but there are things that we can do that can help. Most children become dry at night within 6 months of becoming dry in the day. So sometimes it's a wait and see, let's see what happens. And bedwetting over the age of 5 in children who have been dry in the day for at least 3 months is considered a medical problem called enuresis, and treatment options are available. And do not be fobbed off that your child is wetting the bed because they have Down syndrome. It is nothing to do with having Down syndrome. It's something that affects lots and lots of children, and as I say, even 1 to 2% of adults. We have an information leaflet on our website, and that includes lots and lots of information, including some of the contributory factors and what parents can do to help. And it also goes into more detail about the treatment and the treatment options. As I say, there's lots and lots of information on our website, so do have a look. There's information about constipation, etc., etc., and